and we're going to be discussing the Beyond Celiac Future is Bright Celiac Research in 2024, and we'll tell you a little bit about ourselves. First, I'd like to tell you that the town hall is sponsored by the Illuminate 062 study. The Illuminate 062 study is looking at the safety and effectiveness of an investigational medication designed to break down gluten in the stomach compared with placebo and those with celiac disease who are trying to follow a gluten-free diet. Visit illuminatecd.com to learn more. I'm going to first ask Jordan to introduce himself and tell us about his background and his interest in celiac disease.
Thanks, Deb. It's really great to be with everyone today. Thank you all for joining, taking time outside of your day to be with Deb and myself. So I recently joined Beyond Celiac as my title is Chief Medical Officer, and we'll get into what each of us do in a minute. And I'm a neurologist, specializing in Parkinson's and stroke neurology. Spent some time practicing medicine in the community and academia, and then really had a desire to go into clinical research. And so about a dozen years ago, I moved into the pharmaceutical industry where I help design, run clinical trials, work with the regulators to get drugs approved. And I've had the privilege of doing that in small companies, large companies, biotech companies as a chief medical officer now for, doing that role for 8+ years, many companies. I've got a chance to work on many successful drugs in neurology that have gotten approved. And so, I've been very fortunate to do that and focus on development. And the reason why I got involved in Beyond Celiac is a couple of years ago, my son was diagnosed with celiac disease. And so, as a neurologist, as a researcher who knows neurology really well, obviously I knew of celiac disease, but didn't know it as intimately as I know it now. And so once you have that kind of personal connection to it, which I still need to separate sometimes the parent, the father, the emotion from kind of the clinical scientist, I really started spending a lot of time understanding the disease, drug development about the disease, what's going on, what can we do, what can I do to get a treatment. As someone who's kind of helped develop drugs, get drugs approved for Parkinson's and multiple sclerosis, it's just something that I had to be involved in and help with. So I was very fortunate to, meet all the Alice and everyone at Beyond Celiac, and they were very kind to help, bring me on to help kind of support the cause. So I'm really excited to be here. And then Deb, I want to pass it on to you to give, obviously we're both new. Your introduction. We're all very lucky to have you, given your very strong background. That's obviously very specific to what we're all here for.
Thank you. So I come to Beyond Celiac in a little bit different way. I'm a gastroenterologist with a PhD in immunology. I spent my first half of my career in academia at the University of Pennsylvania. I was on faculty there. And then I went into pharma or industry and started working in clinical development. So I was fortunate to kind of finish my career in industry at Takeda. And Takeda was working on, at the time, 2 treatments for celiac disease. I was the head of their clinical development for GI group. So I oversaw all of the things that they were doing. But my interest is, as a gastroenterologist and as an immunologist, celiac disease, of course, meets both of those, intersects. And I'm just really thrilled to be part of the Beyond Celiac team. I want to go back to Jordan and ask him about what he's working on for Beyond Celiac right now.
And thanks, Deb. I know we're getting questions, and I want to say too, we want to obviously discuss some things too, and then we're going to try to get to as many questions as we can, and we really appreciate this being interactive. And so, Deb, me joining, there's a couple of roles that I have, and I'm really fortunate to work with the outstanding science team who's been doing this for a long time. And really, my 2 focuses: one is on the Go Beyond registry. And so hopefully everyone's aware of it. We really hope everyone participates in, because what we're really trying to do is generate data, right? So the data that's already been generated by both, Erin Miller and Kate Avery, who was doing it before her, have done an outstanding job. And, we're very lucky for all the work they've done. And look at the publications we've generated to really help over the years. And my goal is to help continue to generate more data, so we can use this data, one, for clinicians and academia. We can use it for patients so they can learn more, but also so we can help the pharmaceutical industry and kind of potentially answer questions, help, where we can, to get information get people into clinical trials. And additionally, we're all here. My hope is that we get a drug approved for celiac disease. And fortunate in medicine today, there's a payer element, right? And so we also want to try to generate data to help, look at celiac disease and how it impacts people to ultimately help payers. So that's one of the main, things I'm working on is the registry. Again, we have a lot of great surveys in there now. We plan to do many more surveys this year to continue to gather that data. And then, as I mentioned, the number two thing is clinical trials, right? So Deb and I are fortunate. We've worked on clinical trials for a long time, and clinical trials are hard. They take a lot of work, but we need patients in clinical trials. That's the only way we get drugs developed. So this, working with this Kate, who's been doing a great job leading this, we help with recruitment, right? So what I'm helping kind of recruit for clinical trials, we're trying to work with as many companies as we can to help on the clinical trial side, to help people find clinical trials and screen for clinical trials. And as you mentioned, we have Takeda obviously sponsoring this, and there's many other clinical trials which we can get into. And so a lot of my focus is kind of helping recruit for clinical trials. And I know this year we're also looking to do some more educational seminars on clinical trials. Many of y'all may be really familiar with clinical trials, others may not. And clinical trials are different than clinical practice. So we really want to help do additional webinars and communication and back and forth on what are clinical trials, what are the clinical trials right now, why you should go into clinical trial. Maybe one clinical trial isn't right for you. And so those are my main focuses. And obviously the team's, again, done an outstanding job. We have goals we're setting, and we hope to continue to both generate data, enroll in these clinical trials so we can move the field forward. No, those are my areas of focus. I know, Deb, you're obviously focusing on a lot, leading everything here. So definitely, I'd love for you to tell everyone kind of what some of your main focus has been so far and moving forward.
Thank you. So one of the things that we're working on is a coalition of pharma, biotech, academics, and associations. So like the American Gastroenterological Association, getting all of us together with Beyond Celiac as the lead to be able to do certain projects that we're all interested in. And we call it pre-competitive because there is no treatment that's being sold right now. We can do this where we can all work together. So one of the first things we're doing is with patients, we're going to be discussing clinical trials with the FDA and the barriers to clinical trials to be able to move to a place where it may be easier for patients to be involved, talk about how long the trials are, what's needed in a trial. So that's one thing that the coalition is doing. Another thing that we're very involved in is diversity, equity, and inclusion. And has multiple different aspects to it. One is making sure that all people are able to get screened independent of their socioeconomic background, their race, or ethnicity. So that's something we're working on as well. And lastly, the grants. So overall, I'm in charge of the grants that we're giving. And right now, there are 7 grants that are currently being funded by Beyond Celiac. And I'm going to go through them because I know that as a community, people are really interested in what we're funding and why we're funding these things. So the first 2 grants are designed to study what we call biomarkers or indicators of disease that can either diagnose or monitor disease or both. The source of the indicators or the biomarkers for celiac disease are coming from stool or from blood primarily. The purpose of these studies is to find non-invasive markers that can be used in either clinical care or clinical trials to eliminate the need for invasive procedures such as endoscopy and biopsy to diagnose celiac disease or to measure the effectiveness of either a gluten-free diet or new therapies. So we know that that's a barrier to some to go into clinical trial is the necessity for endoscopy and biopsy. And also for some people for the diagnosis of celiac disease, that's one step that is recommended to do. So if we can have biomarkers, that may help with alleviating that. Another area which probably people have heard of is the microbiome. So we have 2 grants that are focused on the microbiome. The gut microbiota, or the organisms that live in our gut, are very important for our health, but they also may be cofactors in the development of celiac disease by triggering immune pathways in individuals who carry the genes that make them susceptible to celiac disease. So these grants are looking at the microbiome in different ways. One is looking at the immune response against the gut microbiota that precedes the development of celiac disease. And the second grant is evaluating how some bacteria may stimulate the immune response, causing inflammation and the autoimmune response to celiac disease. The first study could lead to predictions of who may ultimately develop celiac disease, while the second study could lead to novel therapeutics based on changing the microbiota to prevent the production of immune stimulation. We also have a grant that's funded by Beyond Celiac that's intended to develop an entirely new research model that mimics the intestine of people with celiac disease. So the grantee is working on an in vitro or out of the body model to grow cells from patients with celiac disease and using also healthy controls in what are called two-dimensional organelles. So this is taking epithelial cells or the cells that line the intestine and making them into what looks pretty much like a small intestine so that you can mimic what the cells might do if if an immune response is generated there. What this does is it really helps us to test therapies outside of the body as an initial step before going towards a treatment in humans. So it could really expand our ability to get new therapeutics. Another grant is directed at understanding why T cells, which is a type of white blood cell that's in the body that activates immune reactions. And these are stimulated and can cause the tissue damage in celiac disease. So this study will lead to a better understanding of the immune responses by T cells and can result in the development of targeted therapy to stop the immune response. And these are more what I call translational. So these are things that can go from the bench to the bedside, we call it. So in the laboratory and then looking at how we can transfer them. This next grant is already a clinical grant, and it's evaluating which interventions can lead teenagers to become more compliant with a gluten-free diet and whether these interventions can translate into better quality of life. Now, this study has the potential to improve the standard of care for treating patients with celiac disease and in turn to improve the lives of individuals with celiac disease. So really a broad range. Many of these things can lead to new treatments or the ability to study treatments in celiac disease. So very exciting and we're funding these because we really want to advance treatments and a cure. So Jordan, what does the future look like in celiac disease, do you think?
Yeah, no, I think that's a great question. And before we answer that too, I think I want to make one comment on something you said with these grants. And I think as everyone said, the bench to the bedside too. And I think an additional grant that I think we're going to have more information on down the road is with Sheffield, right? And I think we saw in the chat there was either some comments or questions about the neurological aspects, because you may be wondering, what am I doing here? But there is a connection with the gut and the brain, which, both for celiac disease as well as Parkinson's disease, other diseases, we know there is a really good connection there. And so, this was clearly something I've been interested in, especially when, my son was first diagnosed, is kind of, although we always focus on the GI, I think the regulators are focused on the GI right now. And I think we hope to broaden that. And I know with all of you who've participated in our surveys on the registry, we've asked about this, we intend to ask more, but specifically one of the grants that we've helped fund is with Sheffield. And so they're a great research unit who has expertise in imaging, expertise in neurology, and their grant is focusing specifically on both neurologic and psychiatric manifestations. Because I think we do know, people have commented on brain fog, headaches, migraines, there is with, gluten exposure, patients with celiac can get that, as well as some of the psychiatric as well. I mean, even though, listen, things like anxiety, depression, is common, there potentially, is we do see that with gluten exposure in celiac disease, with ADHD. And so what Sheffield's looking at is they have kind of a bank of patients that they're following. They have survey data, kind of like what we're doing. They have physical exam data. They have cognitive tests that they're looking at, as well as MRI imaging. And so I know we're really excited to get this information, to see what we see, both, again, how people feel, how you feel, what happens on some of these tests with, with exposure, without exposure, and then what are we seeing on, MRIs over time, to help continue to educate. Because again, one of my focuses, I'm biased obviously, is I want more understanding in these clinical trials. We need to get drugs approved, which obviously Deb is focused on, GI in your neck of the woods, but hopefully we can, we can bring more neurology. And I think, that's where, I think the name of this talk, and where I think you and I join this and are so optimistic, because again, the future is really bright for celiac disease. I mean, even again, so when you go back and study the history of how many clinical trials were there 20 years ago, 10 years ago, and today, I mean, we have, I think I counted, there's 5 or so active trials in the US. There's 4 trials active outside of the US. And those are only the ones that are in the clinic. To your point about the research we're funding, there are things that are kind of still in animals. There are things that are even before animals, in different stages, in healthy volunteers yet, not yet in patients. So the amount of trials that we have, the amount of research that's going into celiac disease is so exciting. The problem is all of this costs money. It costs money to run these trials, to fund these research projects. And so that's why, we continue to help. And that's why we continue need to raise money for celiac disease and support it. Because, with what we're doing with enrolling clinical trials, collecting data, the grants that you're overseeing, we just need to get one. And I think you and I agree on that. We need a treatment. We know things like Crohn's and ulcerative colitis, there were some treatments, and now there's an explosion of all these very good treatments. And there's multiple. You probably see commercials for it every day. And I don't think we see why celiac disease can't be that, but we got to start with one. And I think that's our goal. And we're excited. There's a drug going into phase 3. We have drugs in phase 2. So I'm optimistic. I think we're all optimistic, but we need to obviously continue working really hard at what we're doing.
Thanks, Jordan. We're gonna then, at this point, we're gonna go to some of the questions that were asked ahead of time. And then if there are other questions that are on the chat, we'll get to those as well. So Jordan, why don't you start out? The first question is, will there ever be a pill like Lactaid?
Yeah, so that's a really good question. And that's where kind of, the Tech 062 that you mentioned, Deb, at the beginning, it's kind of a glutenase. It's a similar concept, right? It kind of breaks down the gluten. And so then when it gets, into the stomach, it doesn't cause the immune response. And right now it's being studied kind of continuously, but in theory, it could be potentially used when, there's a risk of going out for dinner, cross-contamination. And so I think in that regard, there's other ones like that as well that are in development. And so I think there's a chance there's something like that. Again, likely won't be over the counter. We do know there are some, over-the-counter products that aren't approved by FDA, but an approved product, proven beneficial. There are types of these medications out there, and I think, I think there's a good chance that one of these will be successful. And obviously depend on, ultimately what the regulators kind of approve it for. But I think, this type of on-demand treatment, or, preventative treatment, if someone's concerned about eating out of the house to help mitigate that, I think we're optimistic there should be something like that.
As a follow-up, someone has asked, how many years away do you think we are from finding a reasonable medication to
Yeah,
lower,
so
this one is to lower the risk of exposure?
yeah, no, that's a great question. And I think it's, again, funny as I look at kind of my child who's in 7th grade, and, most studies fortunately are with adults first and then move forward. But, we have a drug going into phase 3. So a phase 3 trial within, a couple of years for the trial, you got to file with the FDA, as you, as I know, it takes time. It's not as quick as we want, but that could be, 3 or 4 years away. We have drugs in phase 2, which will be a couple of years behind that. But within the next 5 to 10 years, if many of these things move forward, we could have one or more treatments, approved. The reality is we need as many shots on goal as possible. And that's why we need to keep funding and helping research. And, people need to go into these clinical trials, because the more drugs that we have in clinical trials, the more eventual drug approvals we'll get.
And the other thing we find too is that it stimulates, it's almost a catch-22. if a drug gets approved, it stimulates more people to come into clinical research to want to do them. So companies are more interested when they see that something can be approved. So it might be that first drug, and then there's a lot of other people coming in. So, it's something to look forward to.
No, that's a good point, Deb, because I think there's, can someone ask a question, wait, hey, if we get a drug approved, are we going to stop? As you're saying, you have a lot of experience, obviously, much more than me treating Crohn's and colitis. And, when one's approved, the floodgates are open. So I don't think we have any reason to think, again, we're not stopping that. Academia, researchers, pharmas, as you said, likely, I would think, going to be more interested, not less interested if we get an approved drug.
Which is sort of the answer to the next person's question is, once we get a drug, will we lose interest? And actually, we find the opposite is true. Generally, when a drug is approved, then industry starts looking to see, well, can we capitalize on this as well? So it generally spurs more research and more interest than the other. So I would say that it'll continue to go.
I'm going to ask you a couple questions as our expert gastroenterologist and immunologist. A lot of people obviously are concerned about, again, children. Obviously, my son was diagnosed at age 10. Like, what someone asked about kind of mandating testing, and can we do that? Can we not? What's your view on, because now it's basically when you suspect it versus, kind of just testing everyone.
So I'm not sure that we'll get to mandated testing, but the Children's Hospital in Colorado has done a really interesting study where they've tested about 30,000 children. And they've found that 2.4% of those children have celiac disease, which is much higher than you would anticipate when the numbers are like 1%. It's probably much higher because most of those patients that were identified did not have symptoms. At least they didn't report having symptoms. The problem is, and this is true in many diseases, when you have something chronically, you don't actually realize you have symptoms until you treat it and those symptoms go away. So you might also attribute them to something else. So the abdominal pain, so the GI symptoms, the abdominal pain, diarrhea or constipation, the bloating. If you've had this for a very long time, you might not even consider those symptoms until you get rid of them with a gluten-free diet. So
Yes,
when
one.
they, go on.
Oh, no, I was going to say, given and that comment, given if there is an approved drug, because obviously your experience working, launching drugs, getting drugs approved, do you think potentially if there is an approved drug, would a company be more likely to make more notice about celiac disease? I'm not saying it will be mandated, but could that increase kind of the awareness for doctors out there to test more frequently?
It absolutely does. It increases people screening because now they know that there's something to treat with. But what I was going to say is that because patients don't always know that the symptoms are caused by this, when they go on a gluten-free diet and those symptoms go away, they realize that that was the cause of them. And so they're more likely to then stay on a gluten-free diet. But what's important is that when they looked at a lot of these patients, some of them were iron deficient, had iron deficiency anemia, which you can't see outright. And that's one of the things it's in some way can be a silent disease, or some of the neurologic issues, or the ADHD type symptoms in kids, or the poor growth or stature. All these things, if you don't think about celiac disease, you're not going to screen for it. Maybe it will come a time that we do screen, but right now I don't know that we're at that point. I mean, I'd love for more people to get screened, but again, with mandating, it's like mandating anything, it's really hard to do that. But certainly there are a lot of people who are living with celiac disease who do not know that they are.
And then I think, as you said, you've talked a lot about, I know you and I have talked about how the symptoms, sometimes the symptoms don't correlate with histology. And we know for a lot of these trials, there's endoscopy, there's gluten challenge. Like, you see where do these biomarkers fit in? Is there any way where, someone can still monitor their disease, new thing, without endoscopy, because obviously we know people very quickly go off gluten. I think there is concerns about, or certain diseases, it's, you scope people a lot for ulcerative colitis. We don't do that as much with celiac disease, but I'd love for you to elaborate on your views on that.
Well, that's why we're trying to get biomarkers, is so you don't have to do endoscopy all the time. I mean, endoscopy, since I've done hundreds of them, it's in a more or less healthy person. It's really not a big concern in terms of adverse effects happening. It's a pretty simple procedure. And we do actually have endoscopies that you don't even need sedation, depending on where you're going. I would say there's right now, there's more of a necessity to do it because we don't have other ways to really identify whether or not your intestine has, what happens in celiac disease is the immune response causes the intestinal absorptive area, or what we call the villi, to become flattened. And that in turn causes a lack of ability of the intestine to absorb nutrients. So that's why you can become iron deficient, and you can become vitamin deficient as well if you can't absorb the nutrients. So one of the things the endoscopy and biopsy does is it can show you what the extent of your damage is. And that can be actually very important for somebody. So there was, someone had asked a question of how do I get my child to understand that it's important to have a gluten-free diet? Well, I would say a lot of this is silent. It's like blood pressure. You can't feel your blood pressure is high. You can't feel your cholesterol is high. But if you know that your body is causing damage, then you want to do something that's going to alleviate that damage. And in this case, a gluten-free diet, and hopefully some of the therapies that we're talking about. So, growth. We know that celiac disease can absolutely affect the growth of a child. So, these things that may not be apparent in one moment of time, over time can make an effect. The same thing with calcium and vitamin D. If you don't absorb those, your bones can't grow properly and can lead to osteoporosis in the future. So it's the things that happen in the future that we're trying to prevent and correct the things that have happened already.
And again, I can speak to personal experience of that, with my family. It's kind of like when you finally go on that diet, it's kind of like, should we start now? Or should we wait another day? Should we start now? Because once we made that decision, and it's the same concept that I worry about, like I'm for, my good or bad, my child doesn't really had a lot of symptoms before diagnosis. Now, once we know he's been exposed, doesn't get a lot of symptoms. And as we're doing those studies, kids get older and there's birthday parties and there's food at school all the time, which drives me crazy. And it's, we can't control, at least from a children's standpoint, you can't control them. So I think it's a really important point that you make about, although it's silent, you still have to maintain the diet, and there still could be a place for treatment down the road, because there is a percentage of adults too who, I'm not having any symptoms, maybe their blood biomarkers aren't even that bad, but they still could have an active inflammatory process, which could lead to long-term sequelae. And so I think it's just critically important still to, despite having, if you don't have symptoms, to maintain the diet.
So I see kind of in the chat about when you should start screening. So we know that the peak diagnostic time point is between 1 and 10 years old. So we would not recommend screening all newborns because I think you'd probably miss it. You have to have an immune response. And, that's one of the things where one of the grants is looking at is there something we can detect that predates when someone is going to get celiac disease? And we know from studies that you can be negative for a long time, and even in adulthood, start having antibodies to transglutaminase, which is the protein in our body that gluten stimulates the body to have an antibody to. And that's what we usually test. So even if you're screened from ages 0 to 10, it doesn't mean that you can't develop it later if you have a genetic predisposition. So the timing of testing is important too. So if you have a first degree relative who has celiac disease and you want to be tested, test is fine. If it's negative, that's not the end of it. You probably should be tested again in like 5 years or if symptoms occur. So it can develop at different times, and that's important to know as well.
One question we got previously, which is again, I think it's a testament to your science team's great research. I know I go there to get my news. The article that came out by Amy on antibiotics, and I think we had a
Yeah.
question about that. It's ironic. I have another sibling who had to go on antibiotics last week. In the back of my mind, I even mentioned it to the pediatrician. I'm like, you may have not seen this article, but what do you think? So I'd love to get your take on that, because I think that is something that we need to do. Obviously, if you're sick, you need to take antibiotics. But I'd love for you to help walk everyone through that, because I know you can explain it better than anybody.
So what they found, there was a manuscript that was published in Pediatrics, and it was about the use of antibiotics and the development of celiac disease. So, I mean, it was retrospective. They weren't doing it prospectively. So that what they did is they asked people who were diagnosed with celiac disease if how many antibiotic courses have you had. It looks like early years, I think below 5 years, multiple doses or multiple courses of antibiotics, there was a higher association of those people developing celiac disease than if you didn't. But be clear that if you need antibiotics, you should take them. If you have a bacterial infection, what they were saying though is if it's viral, don't take antibiotics. We probably do too much antibiotic use in the United States compared to other countries. Other countries don't use antibiotics as much as we do, but there seems to be a correlation. Now, one of the things they found was there's a protein called zonulin that is elevated in patients who have celiac disease, and zonulin is known to increase what we call the permeability of the gut, or the spaces in between cells. What you want is what we call a tight gut. That means that you don't want a lot of spaces between your cells and the gut, because things can leak in beyond the gut wall. And those things can cause irritation, inflammation. And in this case, it might be how gluten actually gets into the areas where cells can then stimulate an immune response. It might also be that that's how the bacteria that are bad can get into, not cause an infection, but we know that bacteria can also stimulate immune responses. So there might be two reasons why we don't want our gut to be leaky.
And I think
So
that biomarker is interesting. I think is right. Again, as having another child, I said I don't. Again, that's one that I don't think we're regularly able to measure correct. But there are certain drugs. There are actually drugs out there who are trying to protect the intestinal permeability. Correct?
yes, so that is one area of research. It's not just in this disease. Inflammatory bowel disease has the same problem. Is you want to make what they're called tight junctions tight. And so it's interesting that they found that there's a marker that you could potentially use to predict if someone was going to get celiac disease, and that's the zonulin. But what I would say in terms of the antibiotics is be thoughtful about when you use antibiotics, especially if you have a genetic predisposition to get celiac disease. And that's what we call HLA type, and that's a genetic predisposition. That's why families often have more than one person with celiac disease in it, or mother or father, and then the child has it. So it certainly goes into families because it is a genetic predisposition. But not all people who have the genetics get celiac disease. However, the opposite is not true. If you have celiac disease, then it's almost 100% that you have this genetic HLA.
I think
So,
we had a question, again, we talked briefly about the silent celiac. I think someone asked a question about being in clinical trials. And I think just, again, we hope to do more about clinical trials, but the one thing to say is if, when you look at the current clinical trials, there's kind of a population that the FDA wants you to study. And those are, people who still have active disease despite being on a gluten-free diet. We do know in some of the early trials or some of the trials that are trying to get immune tolerance, where maybe you can you no longer get an inflammatory or an immune response when you eat gluten. Those are studying people who have no symptoms, no active disease, and those are usually have some form of gluten challenge. But I think that one is one that, again, I'm very interested as well, because again, as I said, we do think there are a percent that have active disease. And I think what would need to happen is we first kind of, the FDA and these active populations, right, that they want you to show symptoms improve and the histology improves. And so I do think if we can show that both of them improve, which take time, and I think there are challenges in these trials, which your coalition is trying to work with the FDA to make it as hopefully as easy as in quotes as possible to get a drug approved. But if we show symptoms correlate with histology, I would think it's reasonable that somewhere down the road you could just study, again, you wouldn't know it if you have to study people who don't have symptoms, come in, have a biopsy, show you actually have active disease, and then you treat with the medicine, and then you follow them versus placebo, and you show that you improve histology. Again, that's not kind of the first group that the FDA wants us to target, but again, correct me if I'm wrong, I think that's a reasonable path down the road. It's just unfortunately probably not going to be the first path to getting a drug approved based on what the FDA wants today.
yeah, I mean, generally the FDA has sort of a saying. They want people to feel or function better or increase survival. So generally they're looking at feels and functions in a disease like celiac disease. And so they want patients who have symptoms. And it's generally going to be patients who have tried to be on a gluten-free diet and still have symptoms. It is a hard bar too, because then you're talking about potentially just inadvertent exposures, and you don't always know when that's going to happen. So it is a difficult disease because unlike many other diseases, we actually know what causes the defect pretty much is gluten exposure. And that's really unusual. Most other diseases, we don't know that for autoimmune diseases. We know the after effect, like the transglutaminase that I was talking about. We understand that in many diseases, but we don't know what the trigger is. So for like thyroid disease, Graves' disease, Hashimoto's thyroiditis, we know what happens after, but we don't know what triggered it. So this is really unusual, which makes it a really interesting disease to be able to study. But because of that, and there's a gluten-free diet, there's been a lot of reluctance that people who are well maintained on a gluten-free diet shouldn't need a treatment. We don't agree because we think that all people should be able to feel better about their lives and what they do to not have that burden also placed upon them.
And I think that's why, again, what you're doing with the coalition is so important, right? We're funding that. We're trying to get funding from pharma partners to work with academia, to work with the pharmaceutical industry. We're, Deb, your team, I know we have upcoming meetings with FDA to help shape some of that. And so I think that's why it's critically important. And I know, I think I saw a question too about clinical trials and a link for clinical trials. And, as I said, the good news is there are upcoming clinical trials, there are current clinical trials. We hope to very soon this year spend some of these webinars just on some of these clinical trials and talking a little bit more about clinical trials. But as Deb mentioned, that who's helping us today, the Takeda 062, that glutenase, that is currently enrolling in kind of a phase 2 trial, which is kind of the second phase. And they have another drug that's kind of waiting for results. I did mention, Immunogenics is a company that's been around for a long time. They have a glutenase as well. That's going into phase 3. It's not yet, hasn't started, but hopefully the not too distant future, we hope to work with them to help enroll those trials. A company called Enochian has a clinical trial right now, immune tolerance. And so I know we obviously, please go to our website. We very great systemically classify all the different drugs, different trials going on. And so I know, and myself, I'm sure Deb too, we want to be a resource. We want to help, understand which clinical trial might be for you, which isn't. So that's where we want to continue to have many more of these sessions where we just focus on some aspects of the clinical trials.
Yeah, I'm looking a little bit at the chat. It's hard for me to follow it all the time, but um, someone just asked about other autoimmune diseases. There probably is a correlation between other autoimmune diseases. The problem is that that there's not a high enough correlation to say you should screen for everything. One thing that the Colorado Children's is screening for together is type 1 diabetes and celiac disease. Now, type 1 diabetes, I think you'd probably pick that up earlier in your lifetime. It's not something you're going to pick up. Well, I suppose you could, but generally it's picked up earlier in your lifetime because of the problems with glucose and insulin. So that is one that I think they do kind of go together, and you would probably want to screen, especially if it's early on. And again, I think you would just do it based on other symptoms. There might be a correlation between some thyroid diseases, but you're not going to screen everybody for every autoimmune disease because there are just too many of them to start screening for. I don't know if
I think it's probably important, obviously, to mention it to your physician and whatnot, because sometimes physicians don't know the data maybe better than you do. And so I think that is, I know, obviously, advocate. And, as you said, Deb, they're not going to do overly screening, but as you said, as sometimes thyroid disease, it's easy to screen for that, right? Diabetes, you likely as adults, you're probably regularly going to be checking that. Children, maybe not as much. And so I think, although I'm very close to the medical field, obviously, so it's knowing the research, but obviously clearly being your advocate and doing that. And if you have questions, ask about it. Should I be screened? Should my child be screened? I heard there is an association. And again, you don't want to over test, but for things that ought to be tested, we want to make sure that everyone gets that.
Right. So, I mean, I know we touched upon this, but Jordan, I'm actually interested to know what you tell your son. So one of the people asked, like, how do I get my 15-year-old to stay on a gluten-free diet if he doesn't really have symptoms? And if he eats gluten. And again, I said, a lot of things are going on in your body. You just don't know. I mean, it could be an effect later on, like osteoporosis in men is very uncommon, but certainly would be more common if you have malabsorption. So Jordan, how do you approach an adolescent?
Yeah, well, it's interesting because 15 is probably different because 15 is different than 10. My son was diagnosed, and so I think there was some fear. I mean, again, I don't want. I try not. I sometimes more take away emotional from clinical scientists, but clearly, obviously, a lot of emotion with fear of, oh my God, what is this? And I think we were very open about what it was, not like, oh my God, this is horrible. Like, no, like you're gonna be fine. You're gonna live a great life. You're gonna do everything you want to do, but for now, we have to make adjustments to your diet. But if we don't, we want you to be as tall as you can be. We want you to be as healthy as you can be. And so I think for 10-year-old, that worked really well. Obviously, as my child's getting older and you can't keep them in a bubble as much as I want to, and you can't control, when they come home with, a thing of Lucky Charms and you're like, well, are Lucky Charms? And I don't want to talk about that debate, like they're oats, are they cross-contaminated oats or not? But his mind, he read the label and it said gluten-free. And so the control lessons, but I think for me, it was more of the, listen, not, oh my God, this is going to happen, but listen, we want you to be as tall as you can be. We want you to be as healthy as you can be. You play a sport. We want you to be as good as you can at that sport. And so I know, for us that worked really well. But again, trying to emphasize, like, you're going to be fine. Like, and I was lucky. I had people I talked to, and obviously Beyond Celiac and talking to other people who I know, they're like, successful, done well, but you still have to do it. And so I know that's worked well for us. But again, as college and our former CSO, who I talked to him a lot about college and understanding from people about college and what do you do. And so there's a lot that could change as he gets older and is making his own decisions. But that's what we try to focus on. Like, listen, you're doing this to be the best you that you could be.
Thank you. So someone asked a question about somewhat as the terminology. What's the difference between gluten sensitivity and celiac disease? And I actually want to talk about three things. One is, what is gluten sensitivity? What is wheat allergy? And what is celiac disease? So celiac disease is an autoimmune disease. And what that means is that your body is actually attacking itself. It's attacking the either the cells in your body. It has formed antibodies against a protein in your body that we need. And in turn, that attack has caused other white blood cells to then mount an immune response. That's what an autoimmune disease is. So your body is attacking itself. Gluten sensitivity is not an autoimmune disease. It's when somebody who eats something with gluten does not feel well, but their body's not attacking it. It just has to, it's more about how you feel when you have gluten. So when I talked about your lining of the intestine, that you're in celiac disease, the villi, or the place where you're absorbing nutrients, gets flattened. That does not happen with gluten sensitivity. So your villi in your small intestine should look absolutely normal, but it doesn't mean you don't have a problem. The problem is that gluten makes you feel bad, and it could cause almost identical symptoms as people who have celiac disease. It's just that the internal part of it is different. So people can have bloating, they can have brain fog. There's a lot of things you can have with gluten sensitivity, but it's not an autoimmune disease. Now, a wheat allergy is something also very different, and that is when your body does have an immune response, but it's more localized. It doesn't cause, it's not attacking itself. It's a certain type also, it's an antibody response. Usually it's a different type of antibody. It's called IgE that that's stimulated, and it can give you, that can be like the flushing. It can cause some inflammation, but not the same as you have with celiac disease. So those three things are very distinct. But celiac disease is a what I would call a systemic response of your immune system fighting against itself. So they're very different, but some of the symptoms can be the same. And
Yeah,
I
and
would
I think I
say,
forgot to. Oh, I'm sorry. Go ahead, Deb. I
yeah,
interrupted you there.
go on.
I was going to say then that the Sheffield study that we talked about, I think I mentioned probably focusing on celiac disease. That's also looking at gluten sensitivity for the same neurological symptoms, MRI changes or whatnot. And there are some of the drugs out there. So some of the glutenases, when you look, I mean, their focus has been on celiac disease, but they're also looking at studying it in gluten sensitivity as well. So I think there are more trials for celiac disease, but for gluten sensitivity, there are some of these drugs that could potentially work for that as well.
Right, right. So I think I've done, these are the questions that I've answered, I believe are the ones we had ahead of time. But Kate, I don't know if you have anything that has come up on the chat that you wanted to ask.
I do. There have been a few questions that have come up that I think would be great for you guys to answer. I'm going to combine two of them into one question, or into two shorter questions, kind of. How long does it take to feel better after you start a gluten-free diet? And then is there anything you can do to help the process of healing in your body?
I don't have celiac disease, so I probably can't really answer the first part of that question. And I'm not sure that we have a timeline for that, but I don't know, Jordan, do you have a sense of how long it takes to feel better?
Yeah, I mean, I think again, we only from, hopefully as we plan clinical trials, hopefully we can make, people better in shorter amount of time. I know again, in our case, in our family, it was very, very quick in terms of some of the symptoms, but as you know, like the pathology of the atrophy that you talked about, some of the permeability, right? Unfortunately, that doesn't take time and it doesn't necessarily correlate, right? So I think people symptomatically might get better when they're small intestine isn't completely healed, right? And so that's where I think it really varies. I mean, I think, in our experience, it's fairly quick. I know talking to other people, it could be very quick, but the actual histological healing can take time. And that's one of the challenges when we're trying to help develop these drugs and get a drug on the market, when the FDA wants healing of the intestine and reduction of the symptoms. And I know, obviously one of your previous colleagues at Takeda, I think, has kind of published a lot. I think he has a good slide that kind of shows the time course of symptoms and histology. And I think the general consensus, right, is the histology still, complete healing is going to drag, behind symptomatic improvement.
Yeah, I mean, we've looked at studies where even at a year, someone on a gluten-free diet can still have histologic damage. So it can take a long time. We do replenish our gut actually by every 3 days. We pretty much have new cells that are growing in our gut. But it's not just that, it's the immune response you have to change too. So that has to revert back to normal to get your gut back normal. So it does take time. We know from many studies that the symptoms and the histology don't really correlate with each other. So even though you're feeling better, it's very possible that your intestinal cells are not back to normal.
And then one of the things, I guess, as you say, it's immune disease. One question I get a lot in my household is, well, if my labs are better and we think my histology is better, doesn't that mean I can eat gluten? And I think that's obviously, that's, again, the emotional, that's the really, really hard part, right? Because we have memory cells, and just because you could be good for 5 years on a gluten-free diet, you can be exposed again, and it triggers the process to start. And so that's, again, why, fortunately, at this time, it's still, treatments before a cure, but obviously our goal is getting tolerance and having, being able to obviously eat without fear and potentially, eat more foods that potentially at one point you couldn't eat.
So I want to talk a little bit about what this whole issue about tolerance is. So we have two different types of T cells. Those are the white blood cells that cause most of these immune responses. One set are called effector cells. Those are the ones that do the damage. They produce what are called cytokines or factors that increase an immune response. We have another set of T cells. I mean, there are other kinds of T cells too, but these are the main ones. There's another set that are called T suppressor cells, and that's what causes tolerance. When we're born, a lot of what happens is you get tolerance to many things. Otherwise, we'd be reacting to everything. So what we're trying to, not us, but what people in research are trying to do, and in a couple of the clinical trials, is they're trying to induce tolerance against the cells to produce an immune response against gluten. If that can happen, that's towards a cure. Because once you have tolerance and you can't mount an immune response, then you don't have the immune response to gluten or to the glutaminase. So, I mean, that's a real advance in the field if that can happen. And that's one of the things we're hoping for.
And then I guess, is it not quite the same, but I have to help give it in perspective, right? We know people with peanut allergy, and there's been some kind of oral tolerance where you can kind of, again, with peanut allergy, it's still right. So you just don't have an anaphylactic or acute, really bad reaction, but the concept is generally the same, right? You don't mount the immune response to, even though celiac disease is, again, it's different, not an allergic response, but is the concept similar to what, like thinking of like peanut allergy?
It's similar, but a little bit different because it's different kinds of cells that are involved. But it's the same sort of idea, is that you want your cells to not see something as a foreign body, pretty much, even though it's your own. So, Kate, you have anything else for us?
I'm gonna ask another question. This one comes from Monica. Monica says, my 5-year-old daughter went from testing negative to testing positive in 1 year. We have no family history of celiac disease. What might have happened in the 1 year that led to the positive test, and was she affected by celiac disease prior to the positive test?
So that's a really good question. And I sort of addressed that before with, you can have the genetic predisposition, but not have celiac disease, but then later on develop it. We don't know what triggers it. One of the things that a couple of the grants are looking for is, can you identify this early? It's possible maybe her zonulin levels were increased. Maybe was it due to antibiotic use? We don't know. Some people can recall maybe they had a viral infection. We just don't know. There's probably a lot of things that may trigger the body to start the whole process. And but we know that this happens. There's a study that's looking what we call longitudinally. So looking at blood that they have from really decades, and looking to see when someone was not having antibodies to transglutaminase and then had antibodies to transglutaminase, and then looking to see, are there certain predictors of that change. So it's something that we're investigating, or we're giving grants to investigate. It's a really good question, but we, at this point, don't know what the trigger is. Now, the child you're talking about, the 5-year-old, likely, well, almost 100% has the HLA predisposition genes. And so probably other people in the family do too. Otherwise, she wouldn't have them, because it's genetic, it's inherited. But again, it's what we call penetrance, is even if you have the gene, not everybody gets celiac disease. So it's certainly not 100% penetrance. There's some things that are, but in this case, it's not. And there's many more than 1% to 2% of the population have these genes, and not that many people have celiac disease who have the gene. Jordan, did you want to comment on that?
I think that's the importance of, as we wind it down, the importance of what we're doing, the future, because Debbie, you said it, like autoimmune diseases, many we don't know anything. Here we know a lot, right? We don't know everything. You said we don't know everything, but we know a lot. And all the grants, all the research that we're doing about identifying early to see if we can intervene early. And there are companies that are actually interested in this too on the pharma side. But then once you're diagnosed, how can we intervene, the different types of celiac disease, GI symptoms, non-GI symptoms? And so that's why when we said the future is bright, I think we all agree. We know a lot. There's still a lot we're learning. But I think the great news is that so many scientists, so many academic research, so many pharmaceutical companies are targeting this. And that's why we need to keep working hard and doing what we're doing.
So I think, Kate, maybe we can answer one more question.
I think the last one would be, is there any research that's being done on why people with celiac disease are susceptible to certain cancers? And is there anything that we can do to prevent that?
The cancer that we're most familiar with is a type of lymphoma. And that generally happens late in life with a late diagnosis of celiac disease, and it's primarily in men. The thought is that gluten exposure over time, over many, many years, even without the diagnosis of celiac disease, that continued immune reactivity could cause these it's a T-cell lymphoma to occur. So this is where early diagnosis helps in a gluten-free diet, because there is definitely a correlation between gluten exposure and constant gluten exposure and large amount of gluten exposure and the development of these T-cell lymphomas. As I said, they generally happen late in life. And this is where early diagnosis can help. Otherwise, it's very hard, because again, it's more silent. You don't really know you have it. And that's generally the type of person who gets these. And it's really rare to say, it's a very rare cancer. But those people who get it, it's probably that they did not know that they had celiac disease. So it's 3 o'clock. Thank you so much for coming together and listening to us.
Thanks for the time. We appreciate it, and we look forward to more of these. Thanks for taking the time.